This term presenteeism, I think, is really interesting. I'm going to take it back to school with me. That people appear to be there but aren't really describes a lot of my 8 o'clock Monday morning classes. So I now have a phrase to describe it. As I've listened to people talk today, it's been really interesting to hear how much the notion of complexity within the care delivery system is just a given. It's something that all of us accept. It's something that all of us sort of make jokes about. But it's a real problem, and it's a really big problem for lifestyle-affected chronic conditions. The people who have to live every day in their care and who need, or in their health and who need care on a regular basis suffer because there's a tremendous lack of convenience in healthcare. Whenever I go to work with a care delivery organization, I always find the closest McDonald's. And when I get in, I point out to them that, at McDonald's, that's really our competition. They can give our patients 5,000 calories in less than 10 minutes without ever having to leave the convenience of their car. And yet, if you think about a hospital, you have to drive around and around and around in the parking garage just to get past the spaces that are reserved for doctors. And I've yet to find a McDonald's that lets the employees park in the drive-through lot, even though the drive-through lane is obviously much closer. So this convenience thing is really important in ongoing conditions. If it's a one-off and you have to go in, you can deal with that. But when you have to interact with the system over and over, the lack of convenience really hurts. But even more than the lack of convenience, the system that we have, the complexity of the system, leaves enormous gaps and creates enormous obstacles for people. And it is those gaps and those obstacles that are compromising the health effectiveness of care delivery. We spend a tremendous amount of money on health care, but for it we get a very little amount of improvement in health. The value of healthcare delivery is not anywhere close to what it needs to be. And to fix that, we really need to transform care delivery, and we need to transform it in really fundamental ways. It's not just a matter of care coordinators. I remember years ago when care coordination became the big buzzword, talking with a colleague of mine, and I said, how long do you think it will be before we have coordinators of coordinators? Because, pretty soon you're going to have 6 or 8 or 10 or 15 coordinators. Somebody's going to have to coordinate them. 2 weeks ago, I was at a big, very prominent healthcare delivery organization. They now have the manager of healthcare coordinators. So we're up to level 3. I'm not sure how far we're going to go up in terms of coordinators, but the problem isn't that we need to put more layers on top of it. The problem is that we need to fix the fundamental structure of it. And we can do that by taking care of people in the way they experience their conditions, which isn't how healthcare is set up now. If I had diabetes, and I don't, I would need a cardiologist and a nephrologist and a podiatrist and a dietitian. And to get these services, I'd have to go all over town, taking a half day off work each time. We need to set up care delivery that reflects how people experience their conditions and to recognize that 80 or 90% of the patients who have diabetes are going to need all those services, and put those care delivery resources into a team that takes care of people through the full cycle of their care. Now, that transformation isn't going to happen with consumerism. No matter what incentives we give people, we can't get them buying something that doesn't exist. And right now, efficient, effective, convenient care is really an anomaly. And so it's not a matter of putting this onto patients. Which brings me to the chamber connection to this, which is that the most effective, the best positioned change agent for this transformation in care delivery is employers. Providers and plans are making some steps in that way, but they're moving very, very slowly, and consumers can't do it. It really does come down to the employers. And employers both are the best positioned to do it, and they have the best financial incentive to do it. And the question that I always ask employers is, whom do you trust with the health of your employees? Because everybody recognizes that the health of employees is critically important, Whom do you trust to actually manage that? Is there somebody out there that you think can really do it well? And I think the answer right now is there isn't. Employers really are the best positioned because they pay for so much of the profitable health care that's out there. I spent some time in Europe, and I had a translator because the CEOs that I was meeting with preferred to speak German. And the first time it happened, I thought it was a translation problem. The second time, the CEO told me, you know, you American employers, you have a huge advantage over us here in Europe because you pay for your health care. And he said, in Europe, we have to wait for the government to do it, and that's just horrible. So that notion that we pay for it, we ought to be able to drive something is really, really important. But there's also a huge incentive, as Sean pointed out. We in healthcare, we in benefits, we in the employer space focus so myopically on the cost of benefits, but the reality is that the cost of poor health trumps the cost of benefits. Our research shows that it's somewhere between 3 and 10 times greater, the cost of poor health, than it is the cost of benefits. So what we're trying to do is to get employers to create a proactive employee health strategy. And we really think it has to be proactive, it can't just be reactive, and it has to be based on the needs of each employer's employees. It's not a checklist kind of a thing that says, oh, well, you know, we need a big weight loss program. That's great. You might need a weight loss program if you run a trucking company. You might not need a weight loss program if you run Google. So what are the needs of your employees? And you have to really get to a deep understanding of that. And then with that understanding, you can pull 3 different levers. You can change health at work, and I think a lot of employers are moving toward that, although they're not moving as fast on stress reduction. In Europe, stress reduction is a major issue. We worked with one employer who surveys the employees, and if 3 employees under a particular manager report a problem of high stress, they retrain the manager. I was talking to the CEO of a huge US company who said, yeah, you know, at our company, we think of stress as a motivator. And his manager of benefits said, yeah, and have you baselined our cost against everybody else's? That's why we're twice as high. So I think the fixing health at work is a really big thing. It's more than just putting in a wellness program. The second is restructuring benefits so that they result in health. We have these weird distinctions between what's medical and what's not medical. And what we need to do is have a distinction between what results in better health and what doesn't. We should be investing our money to improve health outcomes. And if something improves health outcomes, we ought to be thinking about whether we should be paying for that. We as employers should be paying for that. And then the final thing is to change care delivery. And a lot of employers say, oh, I don't know, I can't do that. Look around at the boards of hospitals. Where do those board members come from? From employers in the community. By and large, they're made up of the people who are the big employers in town. Employers pay for and they have a tremendous amount of opportunity to influence care delivery and to transform care so that it meets the needs of patients rather than meets the needs of the providers.